Thank you, Mr. Chairman and Ranking Member. And I just want to say thank you to the witnesses for being here today as we examine these real pressing issues of chronic disease and ways to bolster prevention and treatment. We've heard compelling testimony from you, thank you, on highlighting the growing burden that chronic diseases pose for our communities: obesity, diabetes, heart disease, all which are straining our healthcare system and impacting millions of Americans. Just a little bit of an overview of my district. In upstate New York 24, we have over 260,000 people of my 774,000 constituents who are enrolled in Medicare. I'll be joining them next year at the same age group. And that represents over a third of our population, which is far higher than the national average, about 18%, so we're over a third. We're one of the more senior districts. And of these Medicare beneficiaries, approximately 180,000 are enrolled in a Medicare Advantage plan, making up about 66% of our Medicare enrollees. This is well above the 54% of the total population enrolled in the MA, or Medicare Advantage. This makes the issue of a Medicare Advantage plan and the benefits deeply relevant to us, especially with my community. So as we look to improve the health care for our older Americans, and I come from just a little bit of an editorial aside, if the Democrats want to scream about health care and Obamacare, come to New York, where ever since Obamacare was passed, premiums have gotten more expensive, health care is more unattainable, everybody's got an insurance card, very few have access to health care, small businesses are being driven out. We have the Democrats control everything, veto-proof majority, and they have done nothing to create or protect a solution for our seniors, for anyone in our state, and is why we have the highest out-migration, the worst healthcare outcomes, all kinds of problems. And it is not because we're not putting enough money into it. We put more money in than anybody else. And so to me, especially when it comes to Medicaid and the essential plan, we're not being fair to our constituents or being fair to the taxpayers on what we're doing. We're not getting good outcomes for the money we're spending. But I would like to see us improve the opportunities we have for our seniors, and especially in the preventative medicine area, diabetes, heart disease, obesity. Those things are really becoming really serious in our communities. And one of the themes that we keep seeing is maybe payment models, allowing the clinicians to move from reactive care to proactive management, something that the chairman loves to talk about, especially preventative care, getting people healthier. How do we get those outcomes? I want to ask my first question for Dr. Hoban, and if you could talk to, how an accountable care organization or a value-based incentive can encourage early identification of risk and intervention for patients with some of the multiple chronic diseases we described, and how are these ACOs, how has their participation with these models helped with hospitalizations, hospitalization costs, readmissions, ER visits? You've done this in both rural and urban areas. What would your opinion be on this, and how can we access this more under this model to make less expensive but more access?
Yes, ma'am. Thank you for the question. I think first and foremost, to your point, is a focus on prevention and screening. So having those incentives there, not only on the care teams that are providing it, but also on the patients to get it. So the more incentive they have to participate in their health care and be active participants in that, we will lead to better outcomes. I think as it comes to thinking about the affordability around the chronic disease management, it's again back to the team care-based model. And when you look at team-based models where patients are getting care from top of licensed partners throughout that team, we see better outcomes. And so physicians and providers can spend more time with the more complex patients, and other ancillary team members can spend time in their areas of expertise. And what we've shown in those models is a significant reduction in hospitalizations, readmissions, use of the emergency room. And I think the MSSP data speaks for itself. It's $2.5 billion when you look at what MSSP has done from a cost reduction. We've experienced that in our ACOs.
That's great. I love the model. But and also, Mr. Chairman, I just want to briefly flag an issue that was raised during the committee's field hearing on rural health last March. At the hearing, members on both sides of the aisle, this was bipartisan, heard from our ground and air ambulance providers that have not seen a meaningful update to their reimbursement rates in more than 25 years. Over that time, costs for fuel, staffing, technology, vehicle replacement, all those things have increased significantly, yet reimbursement hasn't kept pace. And unlike many services, emergency medical services must be ready to respond 24 hours a day, 7 days a week. Whether they are ultimately reimbursed or not is going to be a real problem. Also, particularly important in a rural and suburban district like mine that spans the shoreline of Lake Ontario and all across New York State. This is an urgent issue, and I just wanted to point that out for the chairman and for decision makers on this committee that we need to address that issue. Thank you so much. I yield back.